Our next speaker is going to be Dr. Lonty Bryant. Dr. Bryant joined Merck Animal Health in 2015. He is also a graduate of the great school in Kansas. He graduated from there in 1991. He has a master's in epidemiology from the University of Nebraska. And with that, Dr. Bryant, I will turn it over to you and let you get started.
Remnant Technical Service Veterinarian with Merck Animal Health. Wish this was live because we could start out with a couple of jokes as icebreakers. But since it's recorded, there is proof, and thus there's no plausible deniability. So the Antibiotic Stewardship Project is clinical relevance of antimicrobial resistance expressed in vitro by bacterial pathogens associated with bovine respiratory disease, isolated from the upper respiratory tract of cattle. Let's define clinical relevance as an antibiotic failing to control bovine respiratory disease or as an antibiotic failing to treat a case of bovine respiratory disease. Also contributing to this project are Drs. Van Donkersgoed, Dr. Berg, and Dr. Gordon Brumball. Antimicrobial research, clinical outcomes in BRD. So here's the agenda. We'll go through a fairly extensive overview. We'll look at data sources, methods that were used, and then we'll go into results, both results from wild-type phenotypes, association to clinically relevant outcomes, and non-wild-type phenotypes, association to clinically relevant outcomes. We'll have conclusions, and then maybe look at the future. The vision for the project, the vision to discover and describe quantitatively the relationship of antimicrobial activity in vitro of bacterial pathogens associated with BRD to clinical response in vivo. So do measures and findings in the petri dish / broth culture equate to a clinically relevant outcome or response in the calf. The CLSI standardized procedures determine qualitative endpoints, susceptible, intermediate, and resistant breakpoints. This project relies on those qualitative endpoints for its input. The purpose of the project to qualitatively describe / evaluate the clinical relevance of antimicrobial resistance in suspect bacterial pathogens, the three big ones, Mannheimia hemolytica, Pasteurella meltasta, Histophilus somni, associated with BRD. Quantitative. Let's define quantitative as the predictive value of activity in vitro, assessed as a diagnostic test for response to treatment. So specificity, sensitivity, positive predictive value, and negative predictive value. And again, clinical relevance is defined as an association of an antibiogram to a clinical outcome during a stated observation period. The justification for this project, no or very limited data establishes a quantitative association between antimicrobial resistance as determined by standardized procedures in vitro and subsequent clinical response for BRD in cattle. Veterinarians utilize results of antimicrobial activity in vitro to justify selection and use of antimicrobials in protocols for control of BRD and or treatment of BRD. Antimicrobial products are only approved or labeled for initial treatment or control of BRD, and breakpoints as determined by CLSI use wild-type phenotypes. We actually have no validation from the diagnostic lab on what the antimicrobial sensitivity patterns mean that are generated post-antimicrobial administration. The diagnostic utility of antimicrobial activity in vitro as a predictor of clinical response can be evaluated by calculating sensitivity. So let's define sensitivity as the proportion of failures with isolates that are resistant. So the proportion of BRD failures that have resistant isolates. Specificity, let's define as the proportion of successes with isolates that are not resistant. Positive predictive value of failure. That seems oxymoronic, right? Positive predictive value of failure. But let's define it as the proportion of isolates with resistance that result in failures. And the negative predictive value of success is the proportion of isolates not resistant that result in success. Positive predictive value minus prevalence is the difference in pre-test probability and post-test probability. It provides information to change our minds or confirm our opinions before performing the test. So, is it worth our time and money to perform the test? Will it change our minds on what we are going to do? Let's examine the traditional 2x2 table. Here's a 2x2 table that was used in this project. So response in vitro is down the left-hand side, and there's two categories for response in vitro, either resistant or not resistant. So susceptible and intermediate bacteria are in the non-resistant category, and in a resistant category, of course, contains only organisms that were resistant to a certain concentration of an antibiotic in vitro. Across the top is clinical response. The definition of failure, again, is a calf was given an antibiotic for a control of BRD, and it needed subsequent treatment for BRD. The definition of success is a calf was given an antibiotic as a control, and it did not need subsequent treatment for BRD. Also in this category will be calves that were recognized as having BRD and pulled and treated for the condition and needed retreated. And also in the success category will be calves that were recognized with respiratory disease. They were pulled and treated and did not need subsequent retreatment with the antibiotic. And in these cells will be the numbers that appear from each data source. So failure that are resistant, successes that are resistant, failures that are susceptible, and successes that are susceptible. Then the column totals and the row totals. Examining the 2x2 table and how it's set up to calculate prevalence. Okay, and prevalence, again, is prevalence of failure. And that is either failed to be controlled by an arrival or metaphylaxis dose of an antibiotic, or failed to be successfully treated with a treatment dose of an antibiotic. And these animals will and do have both resistant and non-resistant phenotypes, and it's divided by the entire population. Prevalence can also be called the pretest probability of failure. So the proportion of isolates from calves with failure in the entire population of cattle at the time of sampling. Continuing on with the calculations, we will look at positive predictive value next. And positive predictive value in this project is the proportion of isolates with resistance within all isolates obtained from calves that have failure. And remembering, failure is disease was failed to be controlled by an arrival antibiotic, or disease was failed to be treatment with a treatment dose of antibiotic. This is also called the post-test probability of a failure. Continuing on with the calculations, the negative predictive value is the proportion of isolates that are not resistant that result in success. Sensitivity is the proportion of failures with isolates that are resistant. The last calculation that we'll do is specificity. And specificity is defined as the proportion of successes with isolates that are not resistant. From here, we'll transition into the data sources. 4 of the 6 sources for data are in the public domain. So let's look at each one of them and put a little background behind them. The data sources. So the Donder in 2016, there is data in this publication that was generated around gomethrimycin. And it is my understanding that the data that were generated around gomethrimycin were not utilized by the CLSI to establish breakpoints. Rose in 2014 is data that was generated around tildipyracin, and the CLSI used these data to establish breakpoints for Prevalence. Tessman in 2014, data generated around the research of gomethrimycin, and the CLSI used these data points to establish breakpoints for gomethrimycin. These next 2, Van Donkerskud and Berg, were data that was generated around telithromycin for the control of BRD in calves that are at high risk of developing BRD. And there was also data generated around florfenicol that was used for treatment. So calves were given telithromycin on arrival. So we have either failure or success to control BRD that was generated. And if respiratory disease failed to be controlled in calves that were given telithromycin on arrival, florfenicol was used as treatment. So we have success or failure of florfenicol as treatment of BRD. And this the last publication that's listed here, we're not going to cover it in today's presentation. It is in the overall antimicrobial resistance project, but we simply will not have the time to incorporate all of these into today's efforts. The other thing that I should mention, if I haven't mentioned it before, every one of these data sources, swabs were taken, either deep nasopharyngeal swabs or transtracheal washes, pre-known exposure to an antibiotic, except for the florfenicol that was modeled in the Van Donkerskud and Berg 2016-2017. So in that particular study, again, florfenicol was used after telithromycin had been used as a control antibiotic on arrival. So that probably would not represent a wild type population of bacteria. So let's transition to the methods. We will look at the methods that were used to generate these data in the next couple of slides. So for methods, wild type isolates of Mannheimia hemolytica, Pasteurella motosta, and Staphylococcus somni were obtained from cattle before administration of an antimicrobial medication that is approved for use in cattle to control bovine respiratory disease, or is approved for use in cattle to treat bovine respiratory disease. Antimicrobial activity against those isolates was determined in vitro according to standard protocols described by the guidelines of the CLSI. Results for florfenicol, gomethrimycin, tildipyracin, and telithromycin were classified by respective breakpoints as resistant or not resistant. So again, in the not resistant category, it's got true non-resistant organisms and the organisms that were classified as intermediate. Throughout an observation period described for each study, clinical response to the medication was recorded as success or failure for cattle that are at high risk of developing BRD or that were treated for BRD. And again, success in the control model, a calf that received an antibiotic on arrival and did not require a bovine respiratory disease treatment later in the observation period. And success for treatment would be a calf that required initial treatment but did not require any retreatments after that. And failure would be the opposite of that. So calves that receive an antibiotic at arrival for control of respiratory disease, if they required the respiratory disease treatment later in the feeding period, they're a failure. Same thing with BRD treatment. If the calf required retreatment, it was a BRD treatment failure. Continuing on with methods. Association of clinical response, success or failure, to results in vitro, resistant or not resistant, were assessed using a 2x2 contingency table. The clinical utility of antimicrobial activity in vitro for antimicrobials was assessed using values calculated for positive predictive value, negative predictive value, sensitivity, and specificity. We'll look at results next, and results for specifically wild-type phenotypes, association to a clinically relevant outcome, will be looked at first. It will consist of the results section or the conclusions first. Then we'll look at the data generated from the studies and the analysis to show you why we came to those conclusions. We're going to look at results first and conclusions from the results, and then we'll look at the data to see how we got to this point. So when wild-type phenotype is resistant for macrolides from control or treatment of BRD in 971 head of calves, 843 head were left after excluding no growth. And we'll look at that both ways, with no growth and without no growth. Wild-type phenotypes resistance for macrolides were responsible for approximately 1.5% of the subsequent clinical failures. Positive predictive value and sensitivity indicate that knowing the antimicrobial activity in vitro of wild-type pathogens associated with BRD is not an acceptable diagnostic procedure. The specificity ranges from marginal to high value. Knowing the pathogen was resistant increased the ability to predict a failure by a certain percent. And remember, positive predictive value minus the prevalence could be interpreted as the ability to predict failure. So think about what percent should be filled in here, and here it is. So it increased the ability to predict failure by 5.5%. This table represents the calculations for wild-type isolates of Mannheimia hemolytica, Pasteurella multasta, and Histophilis somni, relating in vitro activity of gamethromycin, tildepyrosin, or tulathromycin. So housekeeping on this slide. Here to the left is the data sources, or the study that the data came from. We have prevalence, and this is prevalence of clinical failure, positive predictive value, negative predictive value, sensitivity, specificity, and the number of animals that were available from each study. Going down to median prevalence. So 50% of the time, clinical failures were more than 13.4%, and 50% of the time, clinical failures were less than 13.4%. Positive predictive value, we won't look at the median because the median for positive predictive value is 0. So the average of the positive predictive value, and you can see the ranges from 0 to 100, is 25. Negative predictive value. Negative predictive value negative predictive value median is 83.65. The average or mean sensitivity is 1.5. The mean specificity is 79.1. So average positive predictive value of clinical failures times prevalence, that equals 0.04875. So 4.9% of the population on average was likely to fail due to resistance. Average sensitivity of clinical failure, 1.5. So 1.5 of clinical failures had a resistant organism, or an organism that had a resistant phenotype. So 1.5% of clinical failures were attributed to resistance. And again, 25 minus 19.5. So knowing that a wild-type pathogen associated with BRD was resistant increased the ability to predict clinical failure by 5.5%. This is the same data that was shown on the previous slide with some subtle differences. The slide is set up a bit differently, and no growth observations have been removed. So clinical failures that were carrying a resistant organism, the cell total is 3. Clinical failures that were not carrying a resistant organism, the cell total is 149. Successes that were resistant, 10. Successes that were not resistant, 681. Then you can see positive predictive value, or prevalence, positive predictive value, negative predictive value, sensitivity and specificity, and then positive predictive value minus prevalence. So the prevalence of failure decreased, prevalence of clinical failure decreased when we removed no growth. Positive predictive value decreased. Negative predictive value increased a bit. Sensitivity and specificity also increased. The test statistic for wild-type isolates of Mannheimia hemolytica, Pasteurella multocida, and Histophilus somni relating in vitro activity of gamethromycin, tildepirocin, and tulathromycin, minus the no-growth observations. So again, antibiogram resistant, not resistant. Failures, 3 and 149, resistant, not resistant, respectively. Successes, 10 and 681, resistant and not resistant, respectively. So the Fisher exact test value is 0.7135. The result is not significant at a p-value of less than 0.05. We can conclude that the variables are independent from one another. And for reference sake, you can see where the calculator for this particular Fisher's exact test is located. Results. When wild-type phenotype are resistant for macrolides. So wild-type phenotypes associated with BRD, there was no significant association of antimicrobial activity in vitro for those antimicrobial medications and clinical response. So we failed to reject the null hypothesis. The null hypothesis being that in vitro wild-type phenotype antibiograms are not associated with in vivo clinically relevant outcome. That finishes the wild-type discussion. We'll transition to non-wild type. Non-wild type phenotypes association to clinically relevant outcome results. We will look at the results first, and then we'll look at two data tables with calculations so that you can see how we got to the results conclusions that we arrived at. So results when non-wild type phenotype was resistant for macrolides or fluorphenicol came from controller treatment of BRD in 348 head of calves, 311 after excluding no growth. Resistance was responsible for 62.23% of clinical failures. Positive predictive value indicates that knowing the antimicrobial activity in vitro of non-wild type pathogens associated with BRD is not an acceptable diagnostic procedure. Sensitivity is a marginal value, a little better than flipping a coin. The specificity is of less than marginal value, less than that of flipping a coin. And knowing that a pathogen was resistant increased the ability to predict a clinical failure by, think of a number, you don't have to share it, increased our ability by 0.03%. So this data table is clinical utility of antimicrobial activity of gramethramycin, telanthromycin, or fluorphenicol in vitro against Mannheimia hemolytica, Pasteurella multocida, and or Histophilus somni for 3 studies of treatment of naturally occurring BRD with non-wild type pathogens. So the study source, Dedander, Berg and Van Donkersgoed, prevalence, positive predictive value, negative predictive value, sensitivity, and specificity, and then the number of animals or observations that were available. So the median prevalence of clinical failure is 25. So 50% of the time, the clinical failures will be more than 25, and 50% of the time, the clinical failures were less than 25. Average clinical failure was 2187. Average positive predictive value is 21.9. So 21.9% of the clinical failures can be predicted by resistance. And if we do 21.9 times 21.87 gives us 0.04789, or 4.9% of the population on average are likely to fail due to resistance. Again, I'll repeat that. 4.9% of the population on average will be likely to fail due to resistance. Average sensitivity, 62.23. So 62.23% of clinical failures will have an organism that has resistance. Average specificity, 37.4. So 37.4% of the clinical successes will have a non-resistant organism. And again, the ability to predict clinical failure, so 21.9 positive predictive value minus prevalence gives us 0.03. So 0.03% of the time, the ability to predict a clinical failure was increased by knowing that non-wild type pathogens associated with BRD were resistant. Chi-score for non-wild type isolates of Mannheimia hemolytica, Pasteurella multocida, and Histophilus somni relating in vitro activity of gramethramycin or fluorphenicol with no growth removed. So the antibiogram, resistance, not resistant, failure, failure, successes. So the observed cell total has no parentheses or no brackets around it. So this is the actual data. The parenthetically expressed number is the chi-square estimate of what should be in this cell. And the number with square brackets is the chi-square value for that cell. So let's read this. Chi-square with 1 degree of freedom, 311 observations, equals 45.52 at a p-value of less than 0.00001. So results when non-wild type phenotypes are resistant for a macrolide or fluorphenicol. Non-wild type phenotype isolates associated with BRD, there was a significant one-sided chi-square test association of antimicrobial activity in vitro for those antimicrobial medications and clinical response. We reject the null hypothesis being in vitro non-wild type phenotype antibiograms are not associated with in vivo clinically relevant outcomes. Conclusions from the current study or project, I think, are pretty straightforward. Conclusions. Antibiograms from wild-type bacteria seem to be of little value with respect to subsequent clinical success or failure. Antibiograms from non-wild-type bacteria seem to have utility with respect to subsequent clinical success or failure. An embarrassing paucity of data exists in the public domain with respect to the utility of in vitro antimicrobial activity association with in vivo clinical outcomes. So where does this leave us, and what should we look to do in the future? I snuck a bonus slide in here. This is not the future. This is an example of other observations or other thoughts. And this would be an example of a 2x2 table attempting to evaluate the diagnostic usefulness of antibiograms obtained from lung tissues, most likely from dead animals, and most likely post-antibiotic exposure. So let's look at the table. And this is not to impugn veterinary diagnostic labs. These are the samples that we send them. This is all we send them. So we have the results, an antibiogram. We have bacteria that are resistant. We have bacteria that are not resistant. We have failures, and they're all failures, right? By default. I went to Kansas State, and even I know if you do a necropsy on a calf, it is a treatment failure. So failure. We have some that have bugs that express phenotypic resistance to 1, 2, or multiple antibiotics. And we have some of these failures that have no resistant organisms cultured post-mortem. And again, all are failures. Successes. We have no successes from the dead pile that we submit to the diagnostic lab. So we have no resistant or not resistant organisms. We can't calculate row totals. We can't calculate column totals. The same scenario applies when we're doing deep nasal pharyngeal swabs or transtracheal washes under the guise of helping us improve our antibiotic selection. When the only samples we obtain are from sick animals or animals post-treatment, i.e. clinical failures, we wind up with this same 2x2 contingency table that provides us with a bunch of numbers that are meaningless. So as we move to the future, I think we need to change our thought process on what we're trying to do when we spend our clients' money generating diagnostic samples. Other observations would be potential limitations of the current project. So it was retrospective. None of the data were a priori. And even though it's the largest assimilation of these types of data, numbers are still extremely small. Future direction. We need to do a prospective study. We have a null hypothesis that clinical response is not different in animals that have bacteria expressing phenotypic resistance. The alternative, of course, would be clinical response is different in animals that have bacteria expressing phenotypic resistance. And as we think about designing these studies, we need to keep some things in mind. We'll have a pool of animals. We'll have some that are excluded for various reasons. They're not BRD. We have a pool of animals remaining that have BRD and that have pre-treatment index tests. Post or pre-treatment index test. So the index test is an antibiogram, or we have no index test. If we have an index test, we have three possible results, correct? Inconclusive or no growth, or lost data. We have organisms that are resistant, and we have two different responses: clinical failure or clinical success. The third possibility, if we have an index test, is that we have organisms that are not resistant. And again, two possible outcomes: clinical failure or clinical success. If we're ever going to come up with an answer that has some robust data behind it, we have to start thinking about asking the right question and researching it the right way. I first became interested or confused in antibiograms when, as a new practitioner, samples would be sent in for culture and sensitivity. Results would come back, and they would not influence my decision-making process or, furthermore, make any sense to me, i.e., I could not find value in the spend. It continued at and through a stint at the University of Nebraska Great Plains Veterinary Educational Center as a lecturer and a researcher. It didn't lessen during my time at Upjohn in the fact that recovering BRD-affiliated bacterial pathogens with phenotypic resistance to ceftiofur is extremely rare. If there is a high direct correlation or even a medium direct correlation between petri dish and broth tube and calf, then why doesn't everyone just use one of the formulations of ceftiofur? The same can be said of the tetracyclines, but on the opposite side of the debate, i.e., how can tetracyclines be used to successfully treat or control anything when resistance patterns are almost ubiquitous throughout all phases of beef production? Currently, the focus is on genotype conferring phenotypic resistance. However, this new passion for genetic identification is fraught with the same errors that we have made in the past, i.e., we are failing to obtain samples from clinically ill and clinically healthy, and we are failing to connect petri dish, broth tube, glassware outcomes to actual clinically relevant outcomes in living and dead calves. I will get off my soapbox and end with that. Thank you. Hello, I'm Lonty Bryant.
Thank you, Dr. Bryant. That was very good. It's kind of confusing, I'll say that, but
I promise you, Harold, I hadn't been smoking marijuana all day. I'd only done 3 recordings, and my voice was tired.
so do we have any questions for Dr. Bryant?
I think everybody left the building.
No, I will ask one question though. I mean, if whether they're multi-drug resistant or drug resistant or not drug resistant, then is that telling us that the viral infections probably play a larger role, or is this more just a management issue? And when I
For
say
some reason,
management issue, I'm talking about treatment, handling of animals, that type thing.
For some reason, you broke up on me, Harold. I could see your lips move.
Okay, so the question is, if we're looking at the biograms and they don't seem to make a difference whether the bugs are resistant or non-resistant, is that telling us that the viral portions of these things are more important, or is it just telling us we don't know?
I got everything but the last. It's telling us that the what is more important, or that we don't know. I couldn't hear the
In other
what.
words, is a viral infection, does it have more influence on this or not?
Harold, we've always looked at things as a single pathogen, right? It seems like we concentrate on IBR or BRSV or PI3 or just go down the list. We've never studied, and I think the reason we haven't studied it is because it's extremely difficult to look at the fractional contribution to disease by each organism, right? Because there's so many iterations that you'd have to look at. So this calf has a pure IBR infection, or this calf has a pure BRSV infection. This calf has an IBR and a BRSV and a Mannheimia and I think it's so difficult to look at fractional contribution to disease just from the bug's standpoint that I'm not sure we'll get there in my lifetime. And by doing that, Harold, I think what we've done is we ignore the calf side of it, right? We ignore making sure we've got the right nutrition, we've got the right comfort zone, we've got the right animal handling, we've got the right animal husbandry. We ignore that part and concentrate on the bugs. And if this data is repeated in a prospective manner and the results come out the same, that antibiograms in the petri dish, laboratory, etc., are not predictive and not associated with an outcome, then we have to concentrate on what is. And that's all the other stuff that goes into making a calf sick or keeping a calf healthy. Does that make sense?
Does to me, but I'd like to hear from the rest of the group.
They're sleeping. I know Dr. Griffin has to have a question.
I guess I'm trying to stay out of the fight.
Have you mellowed as you've gotten more?
Oh no, I'm not mellowed at all. I just have figured out that there are some things that we will fight about, and as you know, I have pretty strong feelings about some things, and antibiotic use is one of them. I'm probably the only person on this entire meeting that is actually a member of CLSI and study their tables religiously, and as you remember from your days at Great Plains, I did the clinical micro and had lots of it's not an as far as I'm concerned, there are two things that have massive influences on our response to therapy associated with bacterial infections, or what we believe are bacterial infections in the lung. And I will give us that we probably, because of historically playing the averages, if a calf comes off a truck and starts looking like the devil in the first, say, 10 days, it's I'm not going to argue that it's not a bacterial pneumonia, but there is a point at which when you look at the physiology or the pathologic changes of this system, the respiratory system during the infection, there's a point at which you couldn't get an antibiotic to the site of the organisms that are in the process of killing this calf if you had dynamite. One of my frustrations early on, I think long before you were, I don't know, I had a fuss with Bill Clay, and I think a lot of Bill Clay, by the way. He was probably the one or two or three best professors I had when I was in vet school, hands down, no question. But I had a fuss with him, and he was trying to pass me off as for whatever. When you start talking about beta lactams, of which ceftiofur is one, you've got to get it across some membranes that it's not very good at crossing. It doesn't have a high volume of distribution. I love the half-life. I mean, you can pick up, I like ampicillin for that matter, but it has a 1.2 hour half-life. So if you're not willing to give it 4 to 6 times a day, you might as well pour a beer on a calf's head. But it's a good antibiotic if you get enough of the drug to the bug. But that becomes another. And ceftiofur, up steps ceftiofur. About the time you went to the Meat Animal Research Center, and you remember Gary, we had all those summer pneumonias. I guess I hope Amelia is on this phone somewhere. We had all those summer pneumonias year after year at the Meat Animal Research Center, and those 90 to 120-day-old calves in average. Some of them may be a little quicker than that, some a little later. And we discussed BRSV, and we discussed this, that, or the other. But we did that study, and I had done it once before. Calves, it was Briggs and Franks that did the study at the Mark that demonstrated those Pasteurella multocida, whatever the microbiologist referred to them, as being that we found in calves as being identical to the ones that serologically that they found in the mothers of those calves. And we did that through necropsy in all those calves that died at an early age, and Briggs and Franks coming out and doing those scopings on those cows. So it became one of those, we'll use Pasteurella multocida as a sentinel for our studies, whether it be CTC in the feed or otherwise. And you can just, I'll go buy anybody on this call a cup of coffee, so long as it's not at Starbucks. I don't have that much money. That you can line up a truckload of calves off a truck and isolate Pasteurella multocida out of their front end of their head, somewhere from their pharynx forward, on about 50% of the calves. And if given the right situation, when it gets in the lungs, it's a pretty bad bug. Now, I'm not trying to discount Mannheim ear, that sort of thing, but those calves were pretty sick in Pasteurella, where our isolates on almost, we got it on 100% of those calves that died. And I say that we didn't culture every calf, but the ones we did, we got it. And Dr. Gary was treating those calves with LA-200 with a dart gun, no less. And they were doing it because you had to rope the cow or rope the calf, and those calves, when you gave them a shot of LA-200, they might not nurse for a week, especially after they've been shot with a capture dart. But I was talking to him, well, why aren't you using Naxel? I mean, we got Naxel at a reasonable, I thought, a pretty good time. It was about the time I showed up. And he said, well, it's a once a day. You got to give it every day. And we can't capture those calves or shoot them every day. I said, no, you don't have to. Naxel has a 10-hour half-life and a peak concentration 14 micrograms per mil if you use the highest dose listed on the label. And the MIC 90 at that time, listed from the FDA and it wasn't CLSI back in the 90s, but from the organization that works on all that stuff, had the MIC 90 at 0.0 for Pasteurella multasta. In 1992, it was 0.06. If you look on the bottles and the data today, it's 0.03 micrograms per mil. But 80 to 90% of that drug is protein bound, and only the unbound drug, or literally 10 to 20% of the peak concentrations, have antimicrobial activity. But even if you calculate that loss in antimicrobial activity associated with the protein binding, which in fact is the reason it has a 10-hour half-life instead of a short half-life like you see in procaine penicillin G, which is in the neighborhood of half that long, or ampicillin that's 1.2. When you dose that, it will stay above MIC 90 for out to about 60 hours. You do the calculations, and that's kind of where it is, and it stays above what that protein total bound. What was it? Scott Brown, I just love him to death, a pharmacologist at Upjohn. Honesty is to the fault. He actually has a deal and he went to a lot of effort to fight out getting put on the label something called therapeutic threshold that would account for that protein binding. At any rate, to shorten this story up by about an hour, we started giving Naxel. He did Naxel 1 dose on those calves, and the response to therapy was so much better than. I mean, you can't, when you give LA200, your peak concentration is 4 micrograms per mil at top, and a half-life on LA200, even as a long-acting drug, regardless of what Pfizer says, or Zoetis, as the case may be, is still less than 21 hours. I mean, it is not the big long-acting drug that somehow we had it in our head. So back to the point, if you've got damage in those calves' lung that you cannot get the drug to the bug, then the bug, maybe it's a little bit like, a terrorist comes in a building, and if we can all get inside a room and lock the door, and the terrorist is locked out in the hall, we're safe. And when the SWAT team gets there and they get out in the hall with him, the terrorist is a dead dude. And if we've got like systemic infections and we have drugs that stay out in the systemic circulation, such as a lactam, it becomes a perfect drug for that sort of septicemic infection, whether it be Histophilus somnus, Pasteurella multasta, Salmonella, whatever it is. Although the Salmonella MIC for ceftiofur is about 1.2 micrograms per mil. But to the point, if I can in fact get in that door with that drug and penetrate it, such that we see with the macrolids, and get it there before you have thrombosis of those vessels, which occurs, according to the Colorado State Bunch, occurs in the first 72 hours after that infection begins. So if you don't have the drug there when that loss of circulation occurs, whatever the diagnostic lab says is irrelevant. The other thing that frustrates me a bit about diagnostic labs is the CLSI books are not that specific. So when you mentioned tetracyclines, and nobody's going to disagree that they're not particularly ever looking pretty on some of our sensitivity data. CLSI doesn't account for the different forms in which we have, or the delivery systems we have for tetracyclines. And the best example I can think of is if you look at the tetracycline data from diagnostic labs, they will tell you that about 90% of your Pasteurella multastas, for which chlortetracycline has an approved label, are sensitive. And that's just in a short note, as if you could see me, you would see my hand sticking straight up in the air like Louis Perino taught us to. That's just BS. Because the 4 studies at Kansas State University, including Donner that you had on this one, they fed chlorotetracycline for 56 days in one of those studies and never did get the serum peak concentration, never did get to 0.5 micrograms per mil. So looking at the 4 micrograms per mil on CLSI data is just ludicrous. But at any rate, you shouldn't have asked me to open my mouth. I could go on for far too long, so I'm going to shut up.
Well, thanks, Steve. No, thanks. We really appreciate your thought and your perspective, and I think it's shared, and we really do appreciate your perspective. I think there's a couple of questions, Lonnie, but I think what we're going to do is probably move on to our next presentation, and maybe you can handle those questions by text or something like that so that everybody can see the answer to those?
Absolutely.
Yeah, okay.